To everyone, hello and welcome to episode 6 of CCLG's Research Talks for Parents and Public. I'm Ellie Wilkinson and my job is to share research with our supporters. So starting with some housekeeping, we'll be holding a Q&A session at the end of the talk, so please do submit your questions whenever you think of one using the Q&A button at the bottom of the screen or in the chat function. If you would like to use the chat function, please make sure you set the to drop down to everyone or people may not see your message. This webinar is being recorded and will be available publicly on our YouTube channel. We will send out the link when it's ready to watch. So this month's talk is called How Powerful is Awareness in Diagnosing Childhood Cancer and is being led by Dr Shaarna Shanmugavadivel. Shawna is a children's doctor working on a PhD in childhood cancer diagnosis. She's also a clinical ambassador for the national award-winning Headsmart Campaign, an awareness campaign that aims to speed up brain tumour diagnosis for children in the UK. So without further ado, I'm going to hand over to Shawna.
So, hello, thank you for having me. Really excited about this evening. So my name's Shawna. So as Ellie said, I'm a children's doctor. I'm not actually an oncologist, so I work in A&E. And I came into the world of childhood cancer about 10 years ago now, where as part of my training, I spent a year working on the oncology ward at Nottingham Children's Hospital. So really, I realised then, speaking to parents, really the difficulties that they faced getting to their diagnosis. And this really sparked my interest in the topic, as I wanted to educate myself really and make sure that we as clinicians in the emergency department and in general practice can promptly pick up the children who need further investigation. And so I've since gone on to work as a Headsmart Fellow, working on the Headsmart campaign, as Ellie said, and I'm now doing my PhD in early diagnosis of childhood cancer. So really, the next half an hour or so will be a little bit of a whistle-stop tour on why and how awareness is a powerful tool in childhood cancer. And really, this is where you as parents, especially parents that have experienced childhood cancer, are so unbelievably brilliant in this area. So I'm continuously in awe and inspired by what parents do in terms of advocating and trying to make this better for children going forwards. And that's really how I came into this world after meeting Angela Palenko many years ago, whose daughter sadly died from a Wilms tumour. So firstly, we will talk about a little bit about signs and symptoms and why this is so important. And then we'll go on to looking at how research plays a really big part in this. So usually when people think of childhood cancer research, they think about finding a cure or about research into the treatment options. So obviously I am really biased, but I feel that this area of research into early diagnosis and raising awareness is really crucial, and we'll talk a little bit about that. And then lastly, as Ellie said, at the end, we'll be having some time for anyone to ask any questions going forward. So let's start by talking about why early diagnosis is so crucial. So if you think of cancer as a ball of cells that are growing, the longer that they grow, the bigger they become. And so it's a lot harder to get rid of with treatment. Now, the bigger that the tumour is, or the more that it's spread, we also need to use more intensive treatment or therapies, usually at higher doses. And so these higher doses have a significant side effects. They can be toxic to other organs. And in the case of radiotherapy in particular, it can increase your risk of developing cancer again at a later age. Now, also when tumours are growing in an enclosed space, like the skull or in the tummy, the bigger they are, the more likely they are to compress nearby structures and organs, and sometimes that causes irreversible disabilities even when the cancer is cured or if the cancer was benign. So a good example of this is in brain tumours. So you can have a benign brain tumour, but the longer it takes to diagnose it, you can be left with blindness, even though the tumour can be taken out and is essentially cured. So this is why the earliest possible diagnosis means better outcomes for our children. Now, the other thing is in adult cancers, there are more options to allow earlier diagnosis. So we have screening. So you can have your cervical screens or your bowel stool kit after the age of 40 or your mammograms that mean that these can routinely pick up cancer at the earliest possible stage, even before you have symptoms. Now, unfortunately, in childhood cancer, we have no viable screening options currently. So when we're looking at the diagnostic journey for these cancers for children, they all start with experiencing some symptoms. So the symptoms are either picked up by the parent or the carer, or in older children by themselves, relate to their parent, and they go to the doctor. And at this point, they're seen by the doctor, and the doctor will request some investigations or refer them to a specialist, and the diagnosis is made. And this sounds really quite simple. But in reality, with childhood cancers, there's often multiple visits to the doctors and some back and forth of investigations as well until the diagnosis is actually made. So why is this? So childhood cancer can be really difficult to identify for a number of reasons. So firstly, the symptoms are non-specific. So what we mean by that is that the symptoms that present can be due to lots of different illnesses and not just specific to cancer. So if we think about the symptoms like pain, vomiting, headaches, tiredness, there are lots of common reasons that we see in children all the time. So symptoms are experienced by children all the time that wouldn't tell us specifically that they were due to cancer. Now, secondly, the symptoms will evolve over time. So there is a fluctuant nature to the symptoms as well. So as the tumour grows, some of these symptoms come and go, and that can be really tricky to pick up. And actually, when we spoke about this with some parents in some research that we did, parents of children who have been diagnosed with cancer, that's what they found difficult. They said that often when their child woke up, they were able to go to school one day, but the next day they weren't. And that fluctuant nature of those symptoms made it really hard for the parent to feel like they didn't know whether they needed to go to the doctor or not. And then thirdly, the age of the child really does impact on how they present. So babies, as we know, aren't able to tell us what's wrong. So if they had a brain tumour and there was increased pressure in the head and they were experiencing a headache, they would cry. And because of that, it's a lot more difficult for us to know what exactly might be going on. And similarly, on the other end of the spectrum, you've got your adolescents or your teenagers who may not disclose symptoms to their parents, especially if they're not aware that it may be something serious, but also because they're embarrassed for whatever reason. So there's lots of different factors that play into why it is difficult to make a diagnosis of childhood cancer, not just for healthcare professionals, but for parents too. So when we're describing the journey to diagnosis, a research team has already developed what we call the Airhouse Statement. So Weller et al. Developed this statement, and they do work in adult cancers, but the reason was to improve or standardize the way that we report early diagnosis research. So it meant that we could then compare across the board to understand. And it defines each step as an interval or essentially their timeframes. So circled at the top is total interval, and that's the time from their first symptom to when their treatment starts. Each component is different and makes up that total interval. And it's really important to understand each of those components if we want to make the overall time to diagnosis shorter. So firstly, the first crucial interval is the patient interval or parent-carer interval for childhood cancer. So this is the time from the first symptom to first presentation. Now, this is likely to be impacted by the things that we've already spoken about. So symptoms are vague, symptoms haven't been expressed to the parent, they've come and gone, so they're quite fluctuant. Some days they look okay. And that's really important. The second important interval is the diagnostic interval, and that has lots of components. So it's the time from first presentation to diagnosis, and it includes first investigation, referrals, specialist visits, and for adult cancers, there's lots of steps. Generally, for childhood cancer, you will go through those steps quite quickly, and you often get your first investigation before you see your specialist, and when they actually suspect that there's cancer, they will refer you to the paediatric oncologists. So for both intervals, as you can see, young people, parents and carers, and healthcare professionals need to be aware of the signs and symptoms that can be due to cancer, so that there's early suspicion and investigation of the children that need it. So hopefully now we understand the importance of knowing about the signs and symptoms to be able to accelerate diagnosis. And now we'll move on to looking at research and how research is helping to raise awareness and accelerate diagnosis. And we'll start with a successful story and then move on to other studies that we're conducting as a team in Nottingham in collaboration with the CCLG that will help us raise awareness and hopefully reduce the time to diagnosis for children and young people across the UK. So let's start with a successful awareness story in the Headsmart campaign. So we've learned a lot from this. So more than 20 years ago, the paediatric oncologist in Nottingham noticed that parents of children with newly diagnosed brain tumours were often remarking on the multiple visits to healthcare professionals, and they were questioning delays that were occurring before they reached their diagnosis. So one set of parents called Angela and Neil Dixon, their daughter, Samantha Dixon, sadly died from a brain tumour in Nottingham. And they were really keen to investigate this and make change. So they founded the Samantha Dixon Trust, which is now known as the Brain Tumour Charity. And they joined forces with Samantha's consultant, who's Professor Walker at the University of Nottingham, and to look at how this could be changed. So firstly, they needed to prove that there was a delay, as all these cases were anecdotal and they had no hard data. So they asked the question, how long does it actually take for children? And so they conducted a cohort study across 3 centres in the UK to see how long it took for children with brain tumours to get a diagnosis. And the results showed that the median time, so the median is the average time to diagnosis, was just under 3.5 months from first symptom. So they then went on to try and help support healthcare professionals because of what we described about it being a diagnostic dilemma and very tricky to tease out some of the symptoms like vomiting, headaches, and they searched the available evidence using a systematic review to understand how brain tumours present in children, and then a consensus process where you get lots of experts together to they rate all of the statements of what should be best practice, and they used all of this to develop a new clinical guideline. Now, at this point, we're in sort of 2008, they audited how well the guideline was being adhered to, and they found that actually not as many people as they thought that were using the guideline were using it to the best that they could be. So they decided that actually they needed to do more to make people more aware. So they translated this evidence-based guideline into an awareness campaign called Headsmart. And here you can see the original branding for Headsmart, Be Brain Tumour Aware. And that was launched in 2011. So 5 years later, that's when I became the Headsmart Fellow, and we did a 5-year review, we rebranded, we relaunched, and since then the campaign's been ongoing. So what exactly is it? So Headsmart campaign is an awareness campaign, and the idea was to empower the public and to inform the profession. So by letting them both be aware of the signs and symptoms of brain tumours, the hope was that it would then accelerate diagnosis. So if the patient and their family's awareness of symptoms and risk was enhanced by a symptom card or supporting information, they would feel empowered to go to their doctors and express their concerns in a positive way with some evidence to back it up. And then if the doctor's awareness was then enhanced and they had a decision support tool to use to help them to figure out who needed to be investigated, then patients would be able to be referred or reviewed or reassured quickly, and the number of repeat attendances would be reduced, and then shortening the time to diagnosis. So that was the hypothesis, that was the idea behind the campaign. So this is just a picture of some of the awareness tools. This is with the second iteration of branding. So there was a website, there was also posters for the healthcare professionals that can be put up in their clinics. There was a quick reference guide that was sort of summarised in this poster here, again to put up in clinic, and there was a decision support tool for healthcare professionals. So they could go to this tool and they could click on the symptom that this child had, and it would tell them what they need to examine, what they need to think about, when they could reassure their patient, and when they needed reviewing or scanning. And that was really, really popular. And then here is this symptom card where it was stratified by age group, what the most common symptoms would be. And that was from an evidence review of over 8,000 patients internationally. And so these were the top symptoms that children would have. And at the bottom of the card, it said, which you can't see very well here, is if you've got one symptom, go to your GP. If you've got two or more symptoms, ask for a referral. So it was very clear for patients and parents as well as to what they needed to do with that information and where to go. Now, having an awareness campaign was all very well, but it was really important to measure outcomes. So, you know, having the intervention, knowing how it works, does it produce any change? So the way they did this was there are 20 principal treatment centres in the UK, and they developed a network of champions through the CCLG. Now, the clinical champions were responsible not only for collecting data on the intervals that we spoke about earlier, but also for promoting awareness and for educating other clinicians in the area. So what were the outcomes? So this was the total interval. And so the blue line is the mean. So the mean is an average. It's found by adding all the numbers in the data set and then dividing by the total number of values in the set. And this is the median. The red's the median, and the median is the middle value when you've lined up all the data from least to most. The median in this particular situation is more useful because the mean will be distorted by that one child that had a really, really, really long time to diagnosis. So we prefer to look at the median. So if we look at the median here, the total interval was a median of 14.4 weeks. And after the guide, and that was the baseline. So after the guideline was published, this had gone down to just over 9 weeks average. And then we'd been monitoring this total interval over the years after the launch, and 4 years after the launch, that come down to 6.5 weeks. So the time to diagnosis across the UK, 20 centres, had more than halved after the introduction of this intervention. So now if we split this into patient and system interval, they called it system interval. What they meant by system interval was the time from seeing a healthcare professional to being diagnosed. So what they said for that was that had gone from 3.3 weeks pre-launch to just over 1 week. And that's the lowest that we can probably get to, because if we're thinking about brain tumours, from seeing a doctor to getting the investigation, which is an MRI scan, which would need to be done under general anaesthetic for most children, that is, you know, relatively quick. Now, when we look at the patient interval, it sort of remained fairly static from 2.5 2.5 weeks to 3 weeks, but there was a bit of fluctuation across there. When we looked at the intervals based on age groups, it was really clear, as you can see here, that your interval was the highest for your adolescent age group, which is something that we had expected and something that had been seen across other illnesses too, and for some of the reasons that we spoke about earlier. So one of the other outcomes we looked at was public impact. So how much reach did this campaign have? So in 2015, we had reached 14 million people, and 20% of the population were aware of Headsmart. Now, from what I can gather, we would have hoped for it to have been better than that, but actually, by all means, people have said that this is, it's really hard to get a national campaign out there that is not, run by Department of Health, to have people this aware of it. So 20% was a win for us. Looking at the website, we had 95,500 hits, or more than 20,000 per month in 2015. And there were more than 2 million cards. These were the symptom cards. This was the first branding of the symptom cards that went out and were distributed. They went through, they were located in Toys R Us, in opticians, they went out in Sunday supplements, and it distributed to GP surgeries across the country. But really, for us, these single case studies are what shows us the real impact on individual people. So this mum had tweeted to say, at Tuesday noon, I saw your website. By lunchtime, my son's tumour had been found and he'd had surgery to relieve the hydrocephalus. Thank you from the bottom of our hearts. That info saved his life. So this was essentially what Professor Walker and Neil and Angela Dixon wanted from this campaign, or could never have imagined would have happened. And it was that individual stories and how it had helped people that we were really grateful for. And as such, because we were able to show through research, through data, that there'd been such a reduction in this total interval through this intervention, it started piquing interest from other countries. So there are many countries who have replicated, not all of them exactly, but some have taken some things like just the symptom cards and the professional materials. Other people have completely replicated. So Jordan have completely replicated Headsmart as a campaign in their country with their own website, with the same branding. And the WHO have got a global initiative for childhood cancer, and part of the work that they've been doing, Dr. Tedros came to visit prior to the pandemic to meet Professor Walker and understand more about how we could use these materials that we've already got here to help other countries meet their targets and improve their diagnosis. So this for us was a successful awareness campaign that has accelerated diagnosis in the UK, and the UK is the first to ever have done anything like this with early diagnosis. So across the world, it's really something that other people are wanting to use and replicate. However, there are always learning points. So this was the first time that the team had done anything like this. There are things that we thought we could do better, and there are things that were far above what could have been, that we could have imagined. So where next? So at this point, this was where 2015 was when I met Angela Polenko, and she came to me at a CR UK Sandpit event, actually. And we spoke about Headsmart, and she said to me, it's brilliant, but what about the other cancers? What about raising awareness of all the other things and making sure that we're promoting early diagnosis? And it's since that day that I have worked with Angela. So Angela is our parent advocate for our studies. And what we learned was that data really drives change. and that awareness is really, really powerful, but that we need the data really, and that it can be done. So since then, what have we been working on? So we want to know how long and what route do children take across the UK to be diagnosed with cancer. So we have set up the CCD study for that. We also knew that actually it was a clinical guideline that made such a difference to healthcare professionals. They felt empowered to be able to know which children needed investigating. And so we, the CCLG, have developed a new guideline which has been published, but we're also doing more individual guidelines for each tumour type or group, so that we can empower clinicians to investigate our children earlier. And then lastly, we wanted to know really what do the public think of childhood cancer? So if we're wanting to raise awareness, what messaging do we need to use? And so the CHIP study has just closed, and we're writing up a bit more about that. So we'll go into this bit by bit. So to answer the first question, like I said, we've launched the Childhood Cancer Diagnosis Study, or the CCD study for short. And it opened on the last day of Childhood Cancer Awareness Month in 2020. It's a collaboration between the University of Nottingham and the CCLG, and it's funded by the National Institute of Health Research. And this was really important to us because we had interest from our health minister at the time, Joe Churchill, who really felt like this was an important step in understanding cancer diagnosis in young people. So the study has been collecting data from all 20 treatment centres over the last 3 years. So it opened to recruitment 2020, it closed to recruitment on the 31st of March this year. And we had to keep it open for longer than we thought because of COVID, and we've had quite a bit of interruption. But we've recruited 1,930 patients, which we're really happy about. And we are looking at factors that affect their time to diagnosis. So we collected data not only on their diagnosis, we collected data on their staging, we collected data on their age, their sex, their ethnicity, their deprivation index, so where they live in the country, and we also collected data on how long it took for them to be diagnosed, and who made the referral and where did they have the investigation. So did they come via their GP? Did they come to A&E? Were they referred, or did they turn up by themselves? And we're hoping to really, really have a good understanding of how children in the UK are being diagnosed. What are the factors that are affecting their diagnosis? Are some tumour types having longer delays to diagnosis than others? Are certain geographical regions having better time to diagnosis than others? And why is this? What pathways are they using? So we're really excited about being able to understand more about how children are being diagnosed. And this is the first time that we will have a national picture on all children's cancer. And we're hoping to use this data to change health policy. So things like 2-week waits, we don't want that for children. We don't think it works for children. There's a lot of data out there to say that only 2% of children who come through that pathway actually end up being diagnosed with cancer. So we don't need that pathway, and it's trying to accelerate that part of the referral process. And hopefully this data will help us change health policy and urge the government to prioritise early diagnosis of childhood cancer. Now, this study is another study that has just finished, and really, if we want to raise awareness, we need to understand what the public know about it. And so we conducted this study to qualitatively, so by that we mean it's more about words and numbers. So we used focus groups to understand and explore what parents think of childhood illness, and in particular childhood cancer, and also how they seek healthcare. So who do they go to? Why do they go? what factors make them decide to go and see someone, and when they go see someone, who do they go to see? Do they go to A&E? Do they go to the GP? And it's trying to understand their health seeking behaviours. And we used 3 groups. So one group was a group of parents who have had to go through a childhood cancer diagnosis with their child, and then we had a group of parents who are lay parents who have never experienced chronic illness in their child. And then we had another group who are parents of children who've got other chronic illnesses such as asthma, epilepsy, diabetes. And what we're trying to do is compare across those groups, whether their health seeking behaviours are different, are their perceptions of cancer different. And we haven't finished analysing all of the data as yet, but there's a lot of exciting data on there. And that's a bit about why, which I've already covered. So exploring and comparing perceptions of cancer, and we use focus groups. So some of the quotes we had from, these are all from parents of children who went through a childhood cancer diagnosis. And a lot of it was about a lack of awareness. So again, like we say, we know that there's a lack of awareness, but we need the data to be able to prove that there is, so that we can make change. And that's why research in this area is really important. So, one parent said, it never comes into your head that it's going to happen, so you don't even think it could be that. And this was talking about the journey to their diagnosis. Again, cancer was never on the radar before we had the cancer. I didn't know anybody who had a child with any form of cancer. Since my son was diagnosed, I finally realised that it's not rare. I thought it was very rare. And also about age. So lots of people didn't actually think that cancer could happen in childhood. And so that's the reason why they didn't think of cancer as a potential diagnosis. So these are all really important things that will help us with our messaging going forward, because the CCLG will be launching Child Cancer Smart. So the idea is it will sit beside Headsmart, and it will be an early diagnosis initiative. So all of this research and results will help us focus and prioritise the awareness and the messaging through Child Cancer Smart, so that we can have the most amount of impact and accelerate diagnosis for these children. So the CCD study will not only tell us what factors affect it and things that we may be able to change, but it will also give us that baseline data of where we're at now, so that we can measure any impact from the campaign. So hopefully now you will also know how research is helping to raise awareness, and how important this research, although I am biased, is. And, hopefully all of the data that we have so far that we're trying to wrap up and analyse will make change in the near future for our children and young people who are sadly diagnosed with cancer. And so now I believe that the floor is yours to ask some questions.
Okay, so we do already have a question on the piece of paper, sorry. So Kent has asked, will the full conclusions and results document from the childhood cancer diagnosis study be published when it's completed, so everyone can see it, not just doctors?
Absolutely. So what we will do is, although it will be published in a journal form for scientific journals, we will also be through the CCLG publishing easy to read format of what those results are. So yes, that will be available on the CCLG website.
Okay, and a follow-up question on that, which he says is probably a difficult question to answer, but when do you anticipate the final results document will be ready for public sharing and all that? Okay.
So we have closed the study and the data is in. However, we're in the process of data cleaning. So that means we have to look through all the data and look at what might be missing, what might not make sense, and go back to the centres. So that process, because there's 20 centres and there's so much data, has taken a bit longer than we anticipated. So we haven't got all of that data back to be able to start the analysis. I would hope that we would have some information out there for Childhood Cancer Awareness Month. And I hope that we would have a full publication by the end of the year. The journal publications take a lot longer to write up, and actually that is the document that we want to get out first because it has all of the information on it. I think we're looking by the end of the year.
Fair enough. So I've got another question. So why don't you still see the Headsmart leaflets in doctor's surgeries? From a lady whose grandson was diagnosed, but she didn't actually see any of them in the surgeries and they wouldn't put them out.
Was this for brain tumours?
Yes, I believe so.
So the difficulties that we had was that we sent out as much as we could. We couldn't send out to every single doctor's surgery. So it was almost that we did a lot of outreach and education, but we also expected surgeries that needed leaflets to be able to request them and come out to them. So I think that was part of the difficulties that we faced. And this is partly why we're trying to get the government and NHS England to be part, or to really take ownership of this campaign this time round. So with Headsmart, we were funding it through donations of the charity. And so printing and sending out and posting were all couldn't be done at such a mass level because we didn't have the money. And that's really frustrating. But that's part of what we've learned from it, is that this time we're hoping that the data that we get from this CCD study will actually be so powerful that we can go to NHS England and say, this needs funding from you, so that actually we are able to get it out to every single surgery and every single A&E, because it will be funded centrally.
It's great that you're using the lessons you've learned. It's definitely going to make it even stronger. So next question is from Leah. She asks, why can't blood testing be used as a first point of action, as it currently seems to be a bit of a last resort?
Yeah, so I think that it is a really tricky one. And I think part of what we spoke about in terms of raising awareness for healthcare professionals as well as parents, I think the difficulty we have is that blood tests, whilst blood tests will tell us about leukemia, for brain tumours, your blood tests will probably be normal. So sometimes doing a blood test can be falsely reassuring. Secondly, in children, we are very mindful of doing tests, and we try not to do tests if we don't have to, mainly because of the distress around doing those blood tests. So I do, but at the same time, I feel all the frustration. So from my A&E hat on, I think, oh, we shouldn't do as many as, if we don't need to do it. But with my, early diagnosis childhood cancer hat on, I hear so many stories, and I can only apologize in terms of every story I hear. I think, gosh, if that had been done earlier, it would have been so much easier. And that's partly why we're doing all the work we're doing in terms of clinical guidelines and really understanding presentation, because with brain tumours, we were able to say, if the child has this, this, and this, you need to go for a scan. And hopefully that's a point that we will get to with, if we get this, this, and this, they need a blood test. And because every tumour type needs a different investigation, hopefully we'll be able to empower the healthcare professionals and parents to be able to ask for those by saying, look, this guideline or this decision support tool says that my child needs this. So hopefully things will get better with the interventions that we're putting in.
Yeah, no, it sounds great. So we've had some more questions in. So Hannah would like to know what lessons can be learned from the fantastic work you're doing on other chronic childhood conditions, for example, diabetes.
Absolutely. You know, I think it's really hard, isn't it? Because when we were raising awareness of brain tumours, we had to be really, really careful, because people said, and rightly so, that we might scare the public in, and think, gosh, it is a scary thing. And we're saying, oh, you've got to look out for this and this and this and this. And it's really, really hard as a parent. I cannot be objective when it comes to my own children. As a parent, to say, oh gosh, I feel overwhelmed with this information now, and I'm now more scared. So too many awareness campaigns will also dilute the message. So I think there's a lot to be learned about using symptom lists. So being able to say, right, this and this symptom, you need to go and do this. And I think that can be learned across other things like diabetes. But I think the important part is knowing where to go to when you need that information. So it's the source. So not necessarily sending flyers through to parents about every single illness, but actually when a parent says, my child's got these symptoms, knowing the best place to go to get the right information to get seen. And that's something we did learn with Headsmart, because when I go and educate GPs or A&E doctors, I say, you don't need to know all of this. I don't expect you to know all of this because you see so much. But what I want you to know is, number one, I want you to have brain tumour as in your list of things, even though it might be a bit further down in your list of things, that it could be this. And number two, I want you to remember Headsmart so that you can go to the website and find the information that you need. And again, this will be what we've learned from this is actually, when we've spoken to parents really do use the NHS website. And again, that's why we want this to be a centrally funded thing, because actually the NHS website is a great website to go to if you think your child's got symptoms. It'll be great if it had a bit of a symptom checker and it could work out what could be wrong. And I think that's something that we definitely have learned. And I think it's about having a central place to put things and using these symptom checklists and guidelines and evidence base to be able to make that diagnosis, and empowering parents and healthcare professionals to do it together.
Okay, so next question on a similar vein. So I'm not quite sure what it means, but perhaps you'll get it better than I do. But so it says, as a parent, having the information for awareness is a good idea. However, it also makes me paranoid in terms of looking for signs all the time. So how many diagnosed patients come from a GP? Maybe perhaps compared to A&E?
Yes. So again, that's what we don't know. So that's what this CCD study data will really, really tell us. So that's so that answer I don't know at the moment, but we will know shortly. In terms of being paranoid, absolutely. And I think this is where, like I said, there's a fine line. And I think actually it should be, once you notice the symptoms, you know where to go to find reputable answers to be able to get a prompt diagnosis. So I think instead of bombarding parents, and this is listening to parents who this is what they've said to us, we don't want to be told all this information, but we want to know where we can get this information if we need it.
Okay, so I've got two questions from Eleanor. So the first one is, what safeguards should be in place when triage process goes wrong? For example, if you don't have a 2-week wait referral system.
Okay, so what we're trying to say is that instead of having a 2-week wait, for children, it should be pick up the phone to the paediatric consultant on call. So the Royal College of Paediatrics and Child Health have a mandate that there should always be a consultant on the end of the phone available locally for every GP to be able to contact daily. So a lot of centres will have a hot week consultant, and they hold the GP phone. And so what we're trying to move away from is, let's do a 2-week wait referral pathway. And actually, if a child comes to you and you are concerned, you should pick up the phone and discuss it with the paediatrician on call and come up with a plan as to where they best should be seen. And sometimes in that case, you know, it will be that child is best seen in what we call a rapid access clinic. So that's usually within the next 2 weeks. Or they might say, actually, can you send them in now? And we'll see them now. Or actually, this probably isn't going to be anything more sinister. So shall we just book them into a standard clinic in 3 months' time for us to keep an eye on it? So what we're trying to promote is that direct contact and picking up the phone as opposed to waiting.
Okay, so then the next question is also from Eleanor. So she's a consultant who works in adult cancer, and when her daughter was diagnosed, she took her to the GP, who took her seriously, but the paediatric consultant disagreed and downgraded the referral. So she'd like to know, how can my daughter's story be of use to researchers and policymakers if a doctor who works in cancer diagnostics struggles to get access to diagnosis for their own child? It suggests there may be significant problems in the system.
That is, you know, I'm so sorry. Again, this is not a story. This is not the first time I've heard that kind of story, and this is what we're trying to change. I think, number one, yes, please, in terms of using your story. So the CCLG have got a link, Ellie, haven't we, where you can submit your own case stories. So it would be great. And Eleanor, if you want to contact me afterwards, if you want to be involved with some of the early diagnosis work, then we, you know, be so grateful. Now, I've heard this many times when I've spoken to GPs as well. So they've said, oh, you know, I referred a child and then the referral got, you know, sent back to me, and I don't know, what do I do? And I think it really needs to, there needs to be a process where you can get a second opinion. So we've spoken about this as well quite often from the stories. So if it gets bounced back, then essentially we are saying take your daughter or take your child to A&E. So if you are not able to get through to an appointment and you're worried about your child, then, you know, A&E is the place to go. If you feel it's an emergency, then you will be seen. The door is always open, and that's what I say to patients that I see. It's not ideal because you have to go there and wait around. But I think there also needs to be, I think the college did, they have published now, because I have seen it in the last year, they have actually published a second opinion kind of standard operating procedure of what happens if you do not agree with what has happened and how to get a second opinion, and that is a protocol in place now. And I think that's come from a lot of stories like this, so that's something also worth looking into. Again, the awareness of the fact that pathway exists now needs to be highlighted, but you know, it's really hard for parents, you know, like you say, you were able to go to a private appointment because you could afford to go to a private appointment. But, you know, as a paediatrician, I don't believe in private practice, because children should not have to pay for their care and they should be receiving the best care that they can receive within the NHS. So, you know, to any parent who is struggling to get answers, who are worried about their children, and especially the gut instinct comes in all of the time. We hear it all of the time. If you've got a gut instinct and you're not getting anywhere, then it is going to A&E. The other thing that I do say to parents as well is being open. So, you know, I saw a parent the other day who came in because their child had been waking up with leg pain, and it was probably growing pains. And so one of the juniors had seen them and came to me and said, oh, you know, actually, I think it's growing pains. There's nothing to see there. I can't feel anything. And the child's fine. So I said, okay. And I went to see them, and mum, I said, what are you worried about? Mum said, I think he's got cancer. And I said, okay, so we talked through it, and I said, okay, so in my gut feeling, I feel that there is a 99% chance that this isn't, but I can't guarantee that it isn't. And without an X-ray, I can't reassure you, which means you're going to come back to me again next week and the week after. So what we need to do here is do the X-ray. And we did the X-ray, and it was okay, but that's okay, because that's the whole point. And so what I say to parents as well is saying really clearly to your, empowering parents to say, I am worried about this. Can you tell me that it's not this? And actually, sometimes it's because us as clinicians, it hasn't even gone through our mind that's what you're worried about. We haven't thought that, gosh, you're worried that there's something really, really wrong. And so we think about common things. We talk about, if you take your car in, I use car as an analogy, you take your car into the mechanic, it's making a noise. The mechanic will, do what they think is normally, what's the most common reason for the car making a noise? Oh, right, I've done this, this, and this. Can you hear the noise? I don't think I can hear the noise. Off you go with your car back home again, and then you can still hear the noise. So you take it back, and then they go through the rest of the list of what they think it might be. And it is a bit like that with medicine. And so, but being very clear as a parent that I am really worried about this. Can you reassure me that it definitely isn't this? It puts the clinician as well a bit, it makes you think, right, actually, can I? I can't. So then I need to do a bit more, or I need to do an investigation to say it's not. But in some cases you can. So with the Headsmart guidance, it was really easy to then go through that with a parent and say, look, actually, they haven't got this, 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 and this. They've only got this. So what you need to do is come back to me in 2 weeks' time, or if any of the other symptoms come about, and then we can do further investigations. And I think having that open communication with the clinician is really important. So everybody saying what they really think can really help make that diagnosis quicker. And I know that it's frustrating. I know that, it's not always as straightforward as that. But it's about trusting your gut instinct and going back if there's a problem.
Okay, so we've got a couple more questions, but I'll just say I will send out the link for people to share their stories if they're interested. And Shawna, do you have any contact details you'd like me to share?
Yes, so if there's anyone who, yes, I can do. So I can give you my email address, which I can pop on there myself if anyone has any further questions.
Thank you. So are you okay for 2 more questions?
Yeah, if there are any more questions, yeah, absolutely.
Yeah. So the first one is from Hannah, and it says, a tricky area, but did you examine at all people's refusal to acknowledge childhood cancer is a thing? For some reason, it's like a swear word. When their child was diagnosed, her older son didn't think he was allowed to say the word cancer in public.
Bless him. So yes, I mean, funnily enough, when someone says, "Oh, what are you doing your PhD in the school playground?" and I say childhood cancer, often I get, they don't want to talk to me about it anymore, because it is really emotive, isn't it? And we have done some exploratory work, and some parents have said, they shy away from it. So when they see it on the TV, or if there's an appeal, they tend to switch over the channels because it's so emotive, and they can't even imagine their child, ever having it, that they don't want to talk about it, really. It is a really difficult area, though, because I know that everyone has their own wish for it. So we've had parents who have had a child diagnosed with leukemia who have not wanted other children to talk about it with their child at school, or mention the word cancer, because they've used the words poorly blood. So I think it is really unique to the individual. And I don't know, it is a tricky question. I don't know how best to address that, really, because I think you're right that there shouldn't be a stigma associated with it. And I think a lot of this kind of going through an awareness campaign will really help people talk about it. So some of the work that we did with parents, they thought that actually only 20% of children survive childhood cancer. So when we told them that it was actually 84%, they were so surprised. So actually that's some messaging that we want to put out there to say, do you know what, actually childhood cancer has got really, really good cure rate and it's getting better, but diagnosing it early is even more important to get your best outcomes. And so changing the public perception of childhood cancer, meaning that all children who have cancer have a really bad outcome and, you know, it results in death, will hopefully help shift that stigma associated with talking about it. So that's our hope.
Okay, so I actually still have 2 questions, if that's okay. So I have another one, which I think is important to ask, because somebody would like to know whether you think it's sort of, that they think that you might think it's the parent's responsibility to say that they think it's cancer as opposed to the doctor diagnosing it at A&E?
No, not at all. Not at all. I'm sorry if it's come across like that. This was based on parents so the focus group, the parents that we spoke to who did have a diagnosis. What they had said is they wished, you know, and again, it was not their fault, but they wished they had been firmer and they had said what they were concerned about. But because they felt that because the symptoms fluctuated, even their family thought that they were overreacting when they thought there was something seriously wrong, which made them not want to share with the healthcare professional that they were really what. So they said they felt from all angles that they were the ones that were overreacting with their child. And so that's why when I speak to parents, I say, please, you know, and I ask the question to parents, you know, what is it? Please tell me, what are you worried about? Because as soon as I can understand that they're worried about something, I can help reassure you or help, think about it myself if I hadn't already expressed it. So absolutely not saying that it's any parent's fault at all, but almost trying to empower you to feel okay to say, you know, there's no such thing as a stupid question or stupid feeling. So if you feel that you're really worried, it's okay to say, I am really, really worried and I think it's this. Can you help me? You know, help reassure me or help diagnose this if it is that.
Yeah, it's like transparency is so important because you can't read minds.
No.
Just knowing what's going on is always going to help. So last question, and it's an easy one. So was the childhood cancer diagnosis study available to those where English wasn't their first language and also for those of a lower education level? There's this brackets equal and diver. I'm not really sure what that is, but maybe
yes. Yes. So if there were, so we didn't automatically make the patient information leaflets available in all languages, but centres contacted us if there was a patient, for example, we did have some patients who spoke Urdu, whether we could get that translated for them or use an interpreter to ensure that they were included. So yes, we definitely, everyone was approached. People who couldn't speak English, there was either an interpreter or the patient information leaflet was locally adapted for them to be able to take part if they wanted to take part. So hopefully we have included everyone that we possibly can.
So I think that comes to the end. So thank you very much for joining us this evening, and thank you to Shawna for your great talk and all of the questions. This talk has been recorded and we will be sending it out over the next few days if you'd like to share it or watch again. You will also be receiving an email shortly asking for your feedback on today's talk. This is so we can make sure our talks are the very best they can be, so please do take a couple of minutes to tell us what you thought. And I will also include some information for you in that. So have a lovely evening, everyone, and thank you very much to Shawna.
Thank you.